Good afternoon. Well, last week we covered diabetes type 1 and its complications, and today we're going to discuss briefly diabetes type 2 as well as diagnosis and treatment management, including again complications associated with type 2 diabetes. If you recall, type 2 diabetes was previously named adult onset or non-insulin dependent. The problem here is that insulin secretions is inadequate because patients have developed resistance to insulin. Hepatic insulin resistance leads to inability to suppress hepatic glucose production and peripheral insulin resistance that impairs at the same time peripheral glucose uptake. This is a brief refreshment for pathophysiology. A combination of insulin resistance as well as the suppression of hepatic glucose uptake gives rise to fasting as well as postprandial hyperglycemia. So you would see that one of the treatments for type 2 diabetes is it would be targeting fasting glucose levels as well as postprandial. Often, insulin levels are very high in patients that have type 2 diabetes, especially early in the disease, but later in the course of the disease, the insulin production may fall. That further exacerbates hyperglycemia. The disease generally develops in adults, even though it could be in child more and more now due to obesity, and becomes more common in increasing age. Very much more common after age 65, but again, it could be related to pediatric population as well. Um, Plasma glucose levels could reach higher levels than type 2, I'm sorry, than type 1 diabetes, even more after eating in younger adults, especially when the patients would eat high carbohydrate loads. Um, African Americans, Hispanic, Latino Americans, as well as American Indians, and some Asians population are particular high risk for type 2 diabetes. It's becoming increasingly commonly now in children, as we already said, due to the epidemic of obesity. Over 90% of adults with type 2 diabetes, they're clear genetic determined, even though some do not have HLA related. Um, there are several genetic polymorphism associated with type 2 diabetes, and the pathogenetics genetic of type 2 diabetes is more complex than type 1. Hyperglycemia develops when insulin secretions can no longer compensate for insulin resistance. And although insulin resistance is characteristic of people with type 2 diabetes and those who are at risk, evidence also exists that some patients have B cell or pancreatic B cell dysfunction and impair insulin secretion. This is one of the reasons why when the patient fails monotherapy as well as combination therapy, you should think about starting insulin as an adjuvant or as solo treatment, monotherapy. It does include the impaired first phase of insulin secretion in response to IV glucose infusion. Patients also could have um, hyperglycemia due to high glucose levels due to B cell in the pancreas be desensitized. Obesity and weight gain are important determinants for insulin resistance, as I said. Um, in summary, patients with type 2 diabetes are obese most of the time. They have sedentarism. Um, we have to target this with exercise treatment as well as nutrition. It should be target, diet. Patients that do have a polymorphism and some have HLA genetic characteristics that we should have into account as well. Patients with insulin resistance not only get complications associated with a hyperosmolar non-ketotic coma, but in addition, patients could develop hypertension, dyslipidemia, and this is important because having dyslipidemia, you would see that, for example, metformin not only um, will decrease glucose levels, but in addition, patients would benefit having decreased lipid levels as well. Vascular diseases develop, and that includes glycosylation of serum and tissue proteins with formation of protein kinase, as well as increased vascular permeability and endothelial dysfunction that could lead to hypercoagulability. Hypertension, dyslipidemia, microthrombosis are few of the possible complications associated with diabetes. In addition to the ones that you already know, which are retinopathy, nephropathy, and neuropathy. Not only that, due to increased lipolysis, increased glucose production, and decreased glucose uptake, patients are at risk for angina pectoris and myocardial infarction, transient ischemic attacks, peripheral artery disease, retinopathies, nephropathies, neuropathies, etc. So we went through the pathophysiology briefly of diabetes type 2. Remember that is a non-ketotic. Remember that these patients do have insulin production. The main problem is insensitivity, and secretory defect is not linked to, even though it does have a component of polymorphism, is not linked to HLA or islet cell antibodies, and most patients are obese. So you have to remember about the metabolic syndrome that we discussed in the first chapter. So what are the signs and symptoms of hyperglycemia? You have, of diabetes type 2, hyperglycemia, the same as type 1, polyuria, polydipsia, polyphagia, uh, because patients are in high degree of catabolism. Patients also have decreased weight, high risk for infections, blurred vision, diplopia, uh, as well as all the complications that we already went through. Now, laboratory data that you're going to basically concentrate on, basically the same as type 1 diabetes. You're going to do the fasting glucose levels. You're going to do the hemoglobin A1C. You're going to be doing the 2-hour postprandial. Remember basically the protocol that we have to follow to be able to diagnose patients with diabetes. So treatment, it would be based on, first, remember these patients are tend to be obese. They tend to have metabolic syndrome. So emphasize on therapeutic lifestyle modifications, including diet and exercise. You have to start with monotherapy when monotherapy fails. And this monotherapy could be an oral hypoglycemic medication if the patient has mild to moderate hyperglycemia. And it could be also insulin when the patient is classified as severe hyperglycemia. And when I say about mild to moderate hyperglycemia is between 200 and 250 milligrams per deciliter, or less than 14 millimole per liter, and severe would be greater than 250 milligrams per deciliter or greater than 14 millimoles per liter. So always try to choose the monotherapy. If the monotherapy fails, then you have to start thinking about combination therapy. So adding a second drug or adding a third drug, or at the end try to add insulin if the patient is not having compensatory hyperglycemia levels. So it means that if the monotherapy or combination therapy has not been effective, then you should think about adding insulin, because remember what we spoke about in the pathophysiology, that these patients at the beginning tend to have high levels of insulin, but lately at the end of the course of the disease, the patients tend to have low levels. So why exercise? Well, exercise is important because exercise will decrease blood glucose levels quickly. It does improve the body ability to use insulin, reduces insulin requirement, improves control for the disease process, and also reduces the risk of heart disease, which is the highest mortality cost for these patients. Now let's go through the treatment of diabetes type 2, which is a little bit more complex than diabetes type 1, because the only thing that you have to remember is insulin. Now in this one, they're oral hypoglycemic, and you need to go back and refresh your memory on the mechanism of action of this group of medications. We have a group which tends to be the first line treatment unless the patient is obese. Those are the sulfonylureas. And those are in the classification of insulin secretagogues, meaning that they're able to stimulate insulin secretion by interacting with the ATP sensitive potassium channel on the beta cell. So when patients have insulin production insufficient, you would like to stimulate the secretion of insulin by giving insulin secretagogues. And one of the groups of insulin secretagogues are the sulfonylurea. Now, the sulfonylurea, there is a first generation and a second generation. The first generation is not listed here because it's not used nowadays. Examples of those are chlorpropamide, tolazamine, and tolbutamide. Now, the second generation is the one that has more rapid onset of action and has a better coverage for postprandial hyperglycemia. And examples of the second generation sulfonylureas are your glipizide, glucotrol, glyburide, diabeta or micronase, and the amaryl or glimepiride. Then you have other types of insulin secretagogues which are non-sulfonylurea, and those are your incretins. And if you recall what incretin is in pathophysiology, is basically a group of hormones that causes an increase in the amount of insulin released by the beta cells of the pancreas. And those are your Starlix, which the generic is natiglamide, or Pandrin, which the generic is repaglanide. Those are orally, but you also have some glucagon like a peptide injection. And example of those are your sitagliptin or Januvia. In addition, there is medications or group of medications that improve the sensitivity to insulin, and those are the thiazolidinediones, or to abbreviate the name, the group of the medications are glitazones. And those basically what they do is decrease gluconeogenesis. Remember that gluconeogenesis is when you do not have sufficient levels of carbohydrates in plasma to be able to convert it into glucose. You go to this first step, which is try to break down glycogen by the liver, and that's called glycogenolysis. Then when that is exhausted, you go into your lipids and your proteins to be able to try to obtain new sources of glucose, and that is gluconeogenesis. Okay, so that is the main function of the glitazones. Decreased gluconeogenesis, so there's no new formation of glucose, and also improved insulin sensitivity. Then you have another group. And examples of the glitazones, you have the rosiglitazone or Avandia, and you have the pioglitazone or Actus. Another group is your meglitinide, which are the alpha glucosides inhibitors. Those are the main functions is impaired response of beta cells, or basically bind to disaccharides uh, to have more readily available the glucose than sucrose. So binds to the saccharides more readily than sucrose, so less glucose is absorbed by the gut. So you could imagine that these medications would have major side effects related to the GI tract. And examples of those are acarbose, Precose, or Miglitol glycet. Another major group will be the excessive production of glucose by the liver, and that would be metformin. And the metformin improved the hepatic response to elevated blood glucose levels and decreased glucose production. And those are the bi-1-ides. So bi-1-ides are the prototype is metformin that basically reduces hepatic glucose production and improves peripheral glucose utilization. It does reduce fasting plasma glucose and insulin levels, and this one is the one that improves the lipid profile and also promotes weight loss. So when patients are obese, the best choice would be metformin. Now, if you remember, one of the main side effects of metformin is that even though it's very good effective as monotherapy, the major toxicity is lactic acidosis. So this medication should not be given in patients that has any type of acidosis related to renal, related to liver, patients that are in severe hypoxemia or decompensated CHF, or patients that should go to any type of radio contrast diagnostic evaluation. So every time the patient will be going to any type of CT scan or any diagnostic evaluation that requires contrast, IV contrast, you should discontinue metformin. And remember the lactic acidosis. Now again, the major groups are bi-1-ides, that your prototype is metformin, glucophage, and the mechanism of action is inhibit glucose production by the liver. Another major group, which bi-1-ides and sulfonylureas, they tend to be the first line of treatment. Metformin for patients that are obese, so you have the advantage of decreased weight, and of course lifestyle modifications and exercise as well, and sulfonylureas in other type of patients would be tends to be the first line treatment. Now the one that we will be using, remember, is the second generation, which your second generation again is your glyphosate, glyburide, and glymeperidide, which your glyphosate is glucotrol, glyburide is diabeta or micronase, and the glymeperidide is the amaryl. And the mechanism of action again increases insulin secretion by the pancreatic beta cells. Then what else can you add into the treatment? Well, you could add all the medications that increase insulin secretion best as second step, and that would be your meglitinides. And examples of those are repaglinide or nataglinide, which is your Pandrin and Starlix. All the medications that could be added is the thiazolinidione or the glitazones to abbreviate, and the pioglitazone actus or rosiglitazone Avandia. And those increase glucose uptake by the skeletal muscle. You must memorize this mechanism of actions. And another group of medications will be the alpha glucoside inhibitors, which is your ascorbols, precoz, or miglytol glycides, which inhibit carbohydrate absorption in the small intestine. Now, going over again before jumping into the major guideline of treatment, remember, for biwanites, you must recall that this medication will reduce fasting glucose levels as well as insulin levels, is the best to improve the lipid profile of the patient, and it promotes a weight loss. It is effective as monotherapy. It could also be combined, but the major toxicity is lactic acidosis. And it should not be given to patients that have renal insufficiency. It should not be given to patients that have any type of acidosis, no volume overload, no liver disease, no severe hyperuricemia, no renal failure. Should be discontinued in patients that are severely ill. So for any type of acute care patients, you do not use any type of oral hypoglycemia. You go straight to insulin. And also remember that it should be discontinued in patients that are planning to have IV contrast diagnostic evaluations, because metformin will promote the contrast nephropathy induced. The sulfonylureas, they are also good for both fasting and postprandial glucose levels. The major side effect is hypoglycemia. You should not drink alcohol with any type of oral hypoglycemia, even less with sulfonylurea and biwanites metformin. Now, one of the side effects for sulfonylurea will be weight gain. So for biwanite, weight loss, and for sulfonylurea, weight gain. So you should not be giving sulfonylureas to patients that are obese. Now, there's cytochrome P450, if you recall that from pharmacology. So it does have a lot of interactions, including the warfarin, including the antifungal medications, the amiodarone, digoxin, etc. Then you have your thiazolinidone or glitazones, that one of the major side effects for those are hepatotoxicity and liver failure. Now, if biwanites has the beauty of decreasing lipid levels, this one has the risk of increasing LDL and triglycerides. It does promote weight gain as well. Now, this one will increase plasma volume. So patients with glitazones are at risk of developing peripheral edema and volume overload states, including CSF. So it is contraindicated for patients that have any type of volume overload, and that includes CSF in the classification of New York 3 and 4, and also liver disease. Another group of medication is the alpha glucoside inhibitors, which is your acarbose or miglytol. And one of the major side effects would be GI. Remember that mainly is gas related. Patients complain that they're not compliant because by not absorbing carbohydrates, patients would have bloating and diarrhea and flatulency, abdominal distensions. So that's the major concern for these patients. And because of that, it should be avoided in patients that have any type of inflammatory bowel disease. Now, this is the mechanism of action of how many medications will work. And we already discussed that. Now, how should I start treatment? What's the major management? So you have to start first with the monotherapy. So initial protocol would be maximize monotherapy. And of course, target physical activity with exercise as well as diet. So lifestyle modifications and monotherapy. So which type of medications I will use? If you have fasting blood glucose levels mild to moderate between 200 and 250, those respond very well to oral hypoglycemic. So which one are you choosing? First line is always either sulfonylurea or metformin. So if the patient is obese and there's no high risk of lactic acidosis or volume overload, as states, then you should go for metformin. If the patient is not obese, they could take a sulfonylurea. And then you start adding. So if the patient has severe hyperglycemia, which is more than 250, you either should add a second therapy or you could go straight to insulin. Now, you always have to go and choose a stepwise approach. So single agent first, and then add a second agent to achieve glycemic target and hemoglobin A1C target. And remember, if the patient has blood glucose levels greater than 250 and even more than 300, I would either choose monotherapy with insulin or I would add my insulin to the second choice. So again, first choice monotherapy, add the second choice if the patient continues to be hyperglycemic in the 300 levels. I would add the insulin instead of going to the third step. Now remember, before you choose the second medication, you have to maximize dose on the monotherapy. So you start low dose, for example with metformin or sulfonylurea. You have to maximize the dose of that monotherapy before you add the second, and you do the same for the second choice until you either add on or you add the insulin. Okay, so now insulin secretagogues that we mentioned already, the classification, they tend to lower the plasma glucose levels immediately. That does not happen with biwanides or the glitazones, that they take several weeks. So you have to have that in mind. If you need to achieve rapid glucose control, you could choose either the insulin secretagogues, which are your sulfonylurea, or the non-sulfonylureas. But if your target is to lower the blood glucose level quickly, biwanides is not going to be your best bet. Now, a reasonable treatment is to initiate, as I said, metformin as initial therapy if the patient is obese, if the patient doesn't have any contraindications such as renal failure, such as CHF, of course in exacerbation, or any type of lactic acidosis, or if the patient is not going to any type of diagnostic that requires IV contrast. Why? Because first, obesity is one of the risk factors for diabetes type 2, and biwanides metformin decreases weight or promotes weight loss, and also lowers insulin levels and improves the lipid profile in addition to the pharmacoeconomics. So choose monotherapy first, then combine. If you would like to add a third drug or even insulin, remember, monotherapy first, maximize. Then if it doesn't work, if the patient continues to have high glucose levels, then add a second drug. It could be metformin with sulfonylurea, which I would choose that. It could be metformin with any type of glitazone. It could be metformin with any type of the peptidyl peptidase 4 inhibitor, which remember your examples are your sitagliptin, Januvia, or sasagliptin, Onglyza. Or it could be metformin with glucagon-like peptide, which it could be the oral Bieta, or it could be the IV1 Victoza. Or it could be, as I said, metformin with insulin. So you could go straight to metformin and insulin as a second combination, or you could go orally first and then add the insulin. or add a third drug. So it's up to the physician's choice. But the first line is monotherapy. You add a second drug, and then you could either add a third drug or add insulin. These are the possible combinations that you could have here. Okay. Now, complications of diabetes type 2. We already spoke about hyperosmotic, non-ketotic syndrome. So, and that, if you recall, is basically a metabolic complication of diabetes that is characterized exactly the same way as DKA of dehydration, hyperosmolar plasma. So there is hyperosmolality, there is alterations of level of consciousness, but the hyperglycemia here is more extreme. It's greater than 600. There is more dehydration state. It mostly happens in patients that have type 2 diabetes. Same precipitant factors. You have acute infections, you have impaired glucose tolerance. It could be related to glucocorticoid use or to the use of diuretics, or it could be just simply due to non adherence to diabetes treatment. Remember that serum ketones are not present because the amount of insulin present is in most patients with type 2 are adequate. So this does not promote ketogenesis. And also because symptoms of acidosis are not present, most patients endure a significant longer period of osmolar dehydration. So these patients would go into higher volume deficit and higher glucose levels. Signs and symptoms are exactly the same. Diagnosis is basically on glucose levels, serum osmolality, and electrolyte imbalances that you would see. And other complications of diabetes is cardiovascular diseases, hypertension, renal failure, peripheral neuropathies, retinopathies, etc. that we already discussed that. Now let's talk about treatment of hyperosmolar non-ketotic diabetes. So let's concentrate on that. First, you have to provide IV fluid replacement. That's the main stem of treatment. How much? These patients have a higher fluid deficit than patients with diabetes type 1, if you recall. So most likely the deficit that these patients would have would be in the range of 6 to 10 liters of fluid deficit. So once a patient becomes hemodynamically stable, or the serum sodium level reaches 145, you change to half normal saline. And also the same as the DKA, when the plasma glucose level reaches 250, you add the dextrose to the IV solution. So if the patient is in hypovolemic shock, you would administer sodium chloride, which is normal saline, 1 liter per hour as a plasma expander. If the patient has mild hypotension, then go and check your sodium level. If the serum sodium level is high, you start with half normal saline. If the serum sodium is low, you continue with the normal saline. Now you have to recall that patients with cardiogenic shock not only do not benefit much with IV fluid, even though these patients need IV hydration, you need to provide ionotropicity as well. Okay. Now, when the patient reaches glucose levels, depending on the book that you're reading, between 250 to 300, now you have to think about a possible drastic drop if you do not add the glucose, the dextrose. So you need to change the IV solution from normal saline or half normal saline to 5% dextrose with half normal saline, and also start decreasing the insulin from a 0.1 to 0.05. Okay, now insulin. The insulin, you basically provide 15 units of regular insulin IV, followed by 10 to 15 units sub-Q immediately. So that would be the same as saying regular insulin 0.15 units per kilo as an IV bolus, and continue with the 0.1 units per kilo per hour as an infusion. Then you check the serum glucose level hourly. If the serum glucose level does not fall by at least 50% in the first hour, double insulin dose. We already went through this in DKA. Until the glucose falls at a steady hourly rate of 50 to 70 milligrams per deciliter. That's not saying that you have to continually monitoring the patient glucose level as well as electrolyte. You have to check BMP every 2 to 4 hours until those electrolytes are stable. Okay? Potassium level. Remember that the only way to eliminate potassium is through the kidney, so the patient has to be urinating. Okay? If the serum potassium level is very low, you do not start insulin treatment, even though that's the main stem for treatment for DKA and HHS, because insulin will bring potassium inside the cell and it will lower even more the potassium that could create cardiac arrhythmia. So if the potassium is less than 3.3, hold the insulin and give 40 milliequivalents of potassium, but the patient must be urinating. If the serum potassium level is greater or equal to 5, do not give potassium. Just continue checking the potassium every 2 hours. If the potassium level is greater than 3.3 but less than 5, you could give 20 to 30 milliequivalents of potassium in each liter of IV fluids to keep the serum potassium level between 4 to 5. And as I said in DKA, once the patient is stable, hemodynamically stable, if the patient is MPO, continue IV insulin and supplement to sub-Q. Then the patient can start eating little by little, clear, and then soft diet and continue to increase. Once the patient start eating, initiate the subcutaneous insulin and of course continue assessing the patient. All the forms of diabetes that you need to be aware of, even though this is acute care, you could be called to an OB unit to be able to manage these conditions. And this is gestational diabetes. Pregnancy aggravates pre-existing any type of diabetes. Gestational basically begins during pregnancy and can develop in overweight, hyperinsulinemic, or insulin resistant women. It doesn't have to be necessarily patients that are obese. It could be thin, balanced, nourished patients. This happens in approximately 5% of pregnancy, but it's higher in Mexican Americans, Indians, and Asian patients. In addition to Hispano-Latino, there is also a tendency of family history of diabetes. It does increase fetal and maternal morbidity and mortality though, so you have to be aware of that. And also the neonates are at risk of respiratory distress, hypoglycemia, and hypocalcemia, hyperbilirubinemia, and many other congenital malformations and even spontaneous abortion. How do you diagnose that? Basically, you would have an oral glucose tolerance test prescribed. You know that there's a normal screening time for pregnancy. They do go through oral hypoglycemia. Oral glucose tolerance test in the second trimester. But basically the diagnosis is based mostly on fasting glucose levels. So if the glucose level in fasting is greater than 126, those patients have gestational diabetes. Or if the random glucose level is greater than 200, the same as in a normal diabetic patient, they are hyperglycemic and they're classified as gestational diabetes. So basically, you could also put the patient on this oral glucose tolerance test, and if the levels are between 130 to 140, you do a second confirmatory test, and instead of a 50 grams of glucose load, you give 100, and if continues to be between 140 range, patient has gestational diabetes. Now, the higher risk for these patients is that even though the disease process disappears once the patient delivers, they do have a 20 to 50% chance of developing diabetes in the next 5 to 10 years. How do you treat these patients? Basically, with tight control of glucose, close monitoring. Um, if the patient has had diabetes in prior pregnancy, you do preconceptional counseling, and concentrate on the complications. So you have to involve not only practitioners and physicians, but also nutritionists in the treatment for this patient. And of course, you don't give oral hypoglycemic medications. You have to give insulin because the oral hypoglycemic produce teratogenicity. Now let's talk about briefly about all the types of diabetes, and that include um, the maturity onset diabetes of the youth, as well as the latent autoimmune diabetes of adult. But in addition, when else can you see hyperglycemic events? In acute care patients, patients that are going through surgery, patients that have a chronic use of corticosteroids, for example, patients that have Cushing's disease, patients that go through infectious process or major illnesses. And that accounts to 1 to 5%, but we do have to manage this in acute care. And remember, any critically ill patient requires insulin. Do not use oral hypoglycemic medications on patients that are critically ill, because this type of disease process increase insulin requirements by increasing glucose production and also impairs glucose utilization. So insulin, if the patient is not critically ill, you could do schedule insulin sub-Q. You could use either sliding scale or the regular insulin, adding the long-acting supplement. But if the patient is critically ill, is insulin drip. Now let's talk about latent autoimmune diabetes of the adult. This is a form of autoimmune disease as diabetes is. Um, the problem is that occurs in adult, often with a slower course of onset. They This type of patients could be diagnosed previously as type 2 diabetes based on their age, because they tend to be older adults, um, particularly if they do have the risk factors of type 2 diabetes, which are the metabolic syndrome or obesity or even the family history. Now, the diagnosis is based on finding high blood glucose levels with the clinical impression that there is islet failure rather than insulin resistance. So, if you do a C-peptide and you do antibodies against the islet Hangerman, these patients do have destruction of the pancreatic cells and high levels of B peptides and high levels of raised antibodies. I'm sorry, low levels of C peptides and high levels of antibodies. And this is what distinguishes type 2 diabetes from LADA. Because remember, type 2 diabetes, even though it does have some genetic factors involved, is not an autoimmune disorder. Um, and also, the main problem is insulin resistance. So patients that have latent autoimmune diabetes, LADA, is autoimmune disorder. So they would have low levels of C-peptides. They would have high levels of autoantibodies against the islets of Hargeman. That it tends to be characteristic of type 1. But instead of being an early onset, these patients develop this disease in adulthood. Okay, so basically, the features are patients usually aged greater than 25 years of age, no younger than this. Um, Clinical presentation in a non-obese type 2 diabetes, even though they could be labeled as type 2 diabetes before, because sometimes they have metabolic syndrome. The initial control achieved with diet alone or diet and or hypoglycemic is not good. Insulin dependency occurs within months, but can take 10 years or more. Other features that are that share with type 1 diabetes is the low fasting and post-glucagon stimulating C-peptide. As I said, they do have autoantibodies against the islets of Hartmann, so you would have HLA, ICA, and some GATA, which are antibodies. Now, about 80% of adults apparently were recently diagnosed with type 2 because it's highly confused. But remember, type 2 is insulin resistance. It's not related to autoantibodies. And these patients with LADA, they tend to progress quickly to insulin within 6 years. So the potential value of trying to identify the difference between LADA and type 2 diabetes is to be able to avoid the use of oral hypoglycemic associated with the side effects related to that. And you know that most of the time the first line treatment in patients that are obese is metformin, and you know the major potential complications that metformin can lead to. So try to distinguish a LADA with type 2 diabetes. Now, another type of diabetes is the maturity onset diabetes that is also has an hereditary form. Is also an autosomal dominant disease. Is monogenic. It has several mutations. One is a transcription factor that is present that leads to insufficiency of insulin released by the pancreatic beta cells. Is so it does disrupt the production of insulin. Um, Very difficult to distinguish between type 1 and type 2 um, because it does include combination of polygenic. You could have associated environmental factors. Um, the major pathophysiology of this is that the MODY form are all due to ineffective insulin production or release by pancreatic beta cells. So there's several of the defects that produce mutation or transcription. One form is due to mutation of the glucokinase gene. Um, So it was sometimes patients originally were diagnosed of MODY. They were based on the presence of non-ketotic hyperglycemic in adolescents. So this is a very common in pediatric population, the maturity onset diabetes of the young. Okay, um, they do also have family history of diabetes. However, they do have genetic testing positive um, related to these autoantibodies. Is very rare. It's basically 1 to 2% of people that are diagnosed with MODY. 50% they have first degree relative with the same mutation. Um, so this is the reason why correct diagnosis is important, but it's very, very difficult. There are two types, as we said. Uh, all of them produce significant hyperglycemia, and of course the typical signs and symptoms of diabetes, which are polydipsia and polyuria. Many people with MODY have no signs or symptoms at all, and they're diagnosed by accident when they go for screening or physical examination, or even to the emergency room. They find very high glucose levels. Insulin may not be necessary, and may be possible to switch a person from insulin injection to oral hypoglycemic medications. Um, Screening is important to be able to target these patients. So again, this is basically less than 25 years of age. Is very, very common in adolescent patients, and sometimes the only symptom that they present with is having a ketotic hyperglycemic event in adolescency or young adulthood. Other types of hyperglycemias, as we mentioned, acromegaly, having growth hormone elevated, produces hyperglycemia. Cushing syndrome, having high levels of cortisol. Thyrotoxicosis in hyperthyroidism. Anything that leads to fight and flight response would lead to hyperglycemia because of gluconeogenesis and glycogenolysis. Patients with pancreatitis, of course, either acute or chronic, any destruction of pancreatic cells, beta cells in this case, would lead to hyperglycemia. Cancer is a catabolic state, so they would have lipolysis and proteolysis. That's the new formation of glucose by gluconeogenesis. And other drugs that could induce hyperglycemia include antipsychotics, beta blockers. Remember that they do not produce hyperglycemia, but they mask the signs and symptoms of hypoglycemia and also inhibit insulin secretion. Calcium channel blockers, corticosteroids, patients with fluoroquinolones, they inhibit insulin secretion as well. Niacin produces insulin resistance, and that's for hyperlipidemia. Phenothiazines, for patients that have any bipolar disorders or psychiatric events, they inhibit insulin secretion as well. Protease inhibitors, they're pro-insulin. Thiazide diuretics, by having insulin inhibition due to hypokalemia and free fatty mobilization. Now, other types of hyperglycemic events are the impaired fasting blood glucose levels, in which basically is a condition in which fasting blood glucose levels is consistently elevated above what's considered normal. However, it's not high enough to diagnose a patient with diabetes. So if a patient has elevated glucose levels between 100 and 125, but not greater than 126, after an overnight fast, is classified as impaired fasting blood glucose level. Or if the patient has insulin glucose tolerance, is basically blood sugar levels elevated between 140 to 199, that we already discussed that in the first presentation, after 2 hours of glucose tolerant test postprandial. Now, there is pre-diabetes that we have to have in mind, that patients that have impaired glucose tolerance level and impaired fasting glucose level, they could progress to diabetes, and we need to continue following up on these patients. And the guideline for ongoing care is basically, you have to teach the patient how to self-monitor blood glucose. You have to test hemoglobin A1C at least 2 to 4 times per year. Educate the patients on hyperglycemia management with exercise and diet. If the patient is diagnosed with diabetes, make them go annually for optometrist or ophthalmologist at least 1 to 2 times per year, to podiatry. Nephropathy has to be annually, so you must follow BUN and creatinine, as well as GFR. Blood pressure, lipid, as well as antiplatelet therapy must be provided, because remember, these patients tend to develop clots. Now, you must recall from pharmacology and pathophysiology as well, these conditions that are SOMOGY and DOM phenomenon. If you remember, SOMOGY is nocturnal hypoglycemia that develops when there's a stimulating surge of counter-regulatory hormones. So patients at 3 o'clock in the morning, they would have a hypoglycemic event, and there's a rebound hyperglycemia due to elevation of catecholamines. So how would you treat this patient? Basically is to reduce or omit the bedtime dose of insulin. Okay. And the Down phenomenon is the result of when the tissue is desensitized to insulin nocturnally. So this patient, if you check the blood glucose levels at 3 o'clock in the morning, they would have elevated blood sugar, but they become progressively elevated through the night, resulting in an elevated blood glucose level at 7 o'clock in the morning. So the difference between the Somogy and Down phenomenon, for example, in Somogy at 3 o'clock, the blood glucose could be 40 milligrams per deciliter, and in the morning it could be 200. And in the Down phenomenon, it could be 160 at 3 o'clock in the morning and progressively goes higher due to the influence of growth hormone. And maybe at 7 o'clock is like 260 or 280. The treatment for Down phenomenon is to increase the bedtime dose insulin or add another type of insulin. Now, let's talk about cerebral edema that is associated with not only with DKA but also with hyperosmolar hyperglycemic syndrome. This most commonly happen in children. Is very, very uncommon. Even though it's less than 1%, you need to be aware, because even though it's most commonly in pediatric population, it could happen in adulthood. The pathogenesis is far from being clear, but is often asserted that over vigorous rehydration, especially when you use relatively hypotonic fluid, could be the primary cause of cerebral edema in such patients with DKAs or HHS. But of course, there's no evidence that support this. So implicating relatively hypotonic fluid in the pathogenesis of cerebral edema is what is basically thought that is the main cause. So there is an intracellular shift of osmosis. Their patients would have, of course, all the manifestations of cerebral edema. So the complication of DKA and HSS, as I said, very common in children. The major risk is the increase with rapid correction of either hypotonic fluids or free water, and rapid decline of blood sugar level. How would you suspect this? Of course, patients could have the signs and symptoms related to cerebral edema, which it come from lethargy to up to coma, and as well as the focal neurological manifestations. But if you hydrate the patient and there's a failure to increase the sodium during treatment of excessive hydration, remember that you basically provide a lot of fluid to DKA and a lot of fluid to patients with HHS, but the sodium is not going up, and the patient now has signs and symptoms of neurological decompensation. You must suspect cerebral edema. How you treat that? Basically, you have to give mannitol from 0.5 to 1 gram per kilo IV over 20 minutes and repeat this in 30 minutes to an hour. If there is no response, you add hypertonic solution to be able to increase the sodium level and to decrease the edema episode and the shifting and intracranial pressure that could be present at that time. So reduce as well the rate of fluid administration by 1/3. Elevate the head of the bed. You must protect the airway in patients that have impending respiratory failure. And you must do a CT scan of the brain to evaluate for thrombus or any type of hemorrhage. But do not delay treatment of reducing the fluid, elevating the head of the bed, starting mannitol if the CT scan cannot be done because the patient, for example, is unstable and cannot be transferred. And this is the end of this presentation.